Okay, good morning, everybody. Welcome to Medical Grand Rounds. After a fabulous and inspirational research day, thanks to our guest speaker and guest judge from yesterday, I'm delighted that he will be presenting Grand Rounds this morning. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I will ask our Associate Chair Research to Dr. Evangelos Mikalakis to come up and introduce our speaker.
We're very honored and lucky to have Peter today. I think Peter is one of the most influential cardiologists definitely in Canada and North America. And I'll tell you why. He is currently the CEO and Vice President for Research at the University of Ottawa Heart Institute that maybe one day we can become like them. They have an integrated system of a hospital and an institute in the same operation. And he is a professor of medicine and physiology. Before going to Ottawa, he was the founding director of the Luer Center of Excellence for Cardiovascular Research in Toronto. And he has also been the chair of the CIHR Cardiovascular Respiratory Council. Peter's research really spans across pillars. It's not just a clinician scientist, because his work goes from fundamental mechanisms, particularly in inflammation and myocardial biology, to biomarker research. He is an imaging cardiology specialist, but he has a basic science lab, but also clinical trials and outcomes research, and including translation of knowledge to the community. He's very much engaged with cardiology communities that also include patients and policymakers in the country. Most recently, he received a ridiculous amount of money, I think a total of $112 million from the federal government, and including a CFREF grant. It's a Center of Excellence. It's one of the things we are trying to do, we haven't achieved in this place. So we asked him to come here to study his phenotype and see what he does. And all I've heard, learned so much is that he lands here at 2 a.m. delayed, and he's up walking around his hotel at 5 a.m. That's tough. So that's how he achieves that. But I think the key, and based on his talk yesterday, is his collaborative spirit and the huge network that he has established both in Toronto and in Ottawa. So that brain heart axis that he got all this money for will be the basis of his talk today. Not, of course, you can imagine that based on what I said, his publications range all the way from Nature Medicine to the New England Journal of Medicine. So usually you have folks that are either or, but Peter actually publishes in these journals and everything in between. Thank you, Peter.
Thanks so much, Evangelos. That's an unbelievable introduction, and certainly privileged to be here. And yesterday, I think the research day, is really testament of the excellence of research here, and a lot of this, is due to leadership, like Evangelos, mentorship and inspiration, and also congratulations to Dr. Kassam, in terms of really, valuing, these type of efforts, and of course, after really, sort of a legendary leaders like Paul Armstrong and Tom Mary and others, so it's really a fantastic programs that I enjoyed yesterday. And so today, I hope, it won't be too disappointing for you, after Evangelist set up. And but also, wonderful colleagues here as well. And Gavin and Zam and Justin and, so all collaborators, and so privileged to actually work with such smart people. And so I will share with you a little bit of story on brain and heart interconnectome, which is a new area they're working on, building on, sort of a previous understanding, whether that's in heart failure, atrial fibrillation biomarkers, as Evangelist mentioned earlier. And so I will, I will discuss this in terms of a case, and then talk about the epidemiology of brain-heart connection. Even though we kind of know this, but we probably don't quite appreciate this perspective specifically. And then, use an example like a biomarker, for example, that actually shows the linkage of these systems, and then how we potentially can actually, take advantage of emerging information, but also look forward to collaboration with the leaders here in the various domains that I'll suggest. And indeed, I always say that one come to Alberta, and we know amazing things can happen. And this is what happens, at the 2 o'clock in the morning when the plane was landing, in the airport, and this is what I see. And of course, this is, played out in your backyard every day, right? So this is how lucky being, sort of Edmontonian will enjoy. And I only get a chance, to see it once in my life. So this is really exceptional welcome, I will say. So it's fantastic. Would make one really appreciate, the power of nature and how things are connected. And so just a brief case, which will be quite familiar to folks here. So this is a 68-year-old lady who's a previous federal high-level official. We have, a number of those folks in Ottawa. And she had previous diabetes, but she came to hospital. This is about a couple months ago. I was on clinical service, so she was a patient that actually came through the emergency department having chest pain, shortness of breath, and a swelling of ankles over 2 weeks. And the ultrasound, the echocardiogram, showed that the ejection fraction was 36%, and normal should be over 50%. And the heart was dilated. And also the NT-proBNP, which is a marker for heart failure, was 1500. Normal should be less than 125. High-sensitive troponin was mildly elevated at 85. And so the diagnosis is that she has acute heart failure. Now, of course, common things being common, one would think that this may be coronary artery disease. But on the other hand, the coronary angiogram is completely normal. And as this is really then, sort of challenges us to actually figure out this is a dilated cardiomyopathy, myocarditis, etc. But the left ventricular angiogram shows that there is a apical ballooning, so this obviously gives us a clue. And in retrospect, when one actually carefully gets a history, the patient, a very close sister, who actually died just 1 week before. And she was totally emotionally distraught from this. And so this is obviously, the classic case of Takotsubo cardiomyopathy or stress cardiomyopathy. And so the patient was treated with GDMT, in terms of a heart failure. And, Justin was just mentioning, the European meeting, so really emphasized the heart failure, new treatments. And that she also received a supportive psychotherapy, and the follow-up, she has actually made a good recovery. And but this is the type of situation when one really, epitomizes the connection, between the brain and the heart. And but this is not the only one, right? So there are many, many other connections that we don't necessarily think about on a daily basis, but it really actually is very fundamental, to medical care. And so in terms of the Takatsubos, and so generally the current understanding is that, there can be emotional or physical stress and that leads to massive discharges of signals from the heart, whether that's directly, through the autonomic nervous system or through neurohormones in the circulation, that actually leads to microvascular spasm, microvascular constriction in the heart, leading to this very acute remodeling of the heart. And fortunately, some of this can recover. It used to be we think that every case of Takotsubo will recover, but that's not true, because when you actually look at a large Swiss series published in New England Journal, that 1/3 will actually fully recover, 1/3 will actually have heart failure progression and develop into long-term cardiomyopathy, and so that not everybody, in fact, will completely recover, and this is important to actually realize. And so it's also important to actually think about sort of a diagnostic criteria, and so this include the regional wall motion abnormalities in the absence of coronary artery disease as etiology, and but also absence of for example myocarditis or other etiological explanation for the patient's heart failure. And there has been an INTERTAX score that sometimes can be used, and particularly if you have a score over 50, then it's a high specificity for Takatsubos. Less than 30 is more likely to be acute coronary syndrome. And so, but you can see that the top points are given when the patient is female, there is an emotional or physical trigger, and the absence of classic SD segment changes compatible with ischemia. And but it's interesting that even on the current guidelines, for Takatsubos, in fact, it's usually in a kind of the last section in the typical guidelines. So it's not the sort of a front of the mind. And one would actually, for example, the patient is just to have a congestive heart failure. Usually, it's just the usual guideline treatments, the quadruple foundational therapy, for example, for a patient with heart failure with reduced ejection fraction, or if the patient has cardiogenic shock, that will need to be supported, certainly in a temporary basis until the patient can recover enough to receive the evidence-based therapy. But one thing which is not actually indicated here is, in fact, addressing the trigger. So all the guidelines, just focus on the heart and the heart-related treatment, right? And so there is actually no mention of things like, in terms of mental health support, trying to address the underlying pathophysiology, that actually started this whole process. And it shows the gap, in which we tend to, compartmentalize, patients according to kind of our own kind of a comfort zone in the specialties. And what we really now realize that, in fact, when we deal with the common, sort of whether it's cardiovascular problem or, brain-related problems, there is actually interconnection between the two that we generally don't necessarily think about, whether it's in a heart failure, atrial fibrillation, the patient, in fact, has risk in terms of developing stroke, developing cognitive impairment, and certainly associated mental health challenges. And vice versa, patients with stroke obviously can actually lead to development of heart failure and cardiovascular complications as one of the major causes of death, for example, patient with stroke. And also stroke itself leads to dementia and cognitive impairment, which is not something that we tend to actually follow up with the patients with. And indeed, for example, if you actually look at the burden and the linkage from an epidemiology point of view, as for example, area like heart failure, which is one of the key clinical practice that I have, is that now it's close to 1 million patients with heart failure in Canada, but in fact about 40% of the patients with heart failure can have a transient or sometimes long-standing depression. And mental health is a major challenge for the patients, but I don't think we routinely necessarily screen for it. And similarly, cognitive impairment is a major challenge. And this also can occur, anywhere between 20 to 30% of the patients. And it's something the patient worries about. But, we tend to just blame the patient when they can't remember to take, 8 to 10 medications, right? And rather than not realizing, in fact, there is actually a biological reason that they can't actually take those medications. And similarly, the classic obviously will be atrial fibrillation, in which we know this is very much associated with stroke. Anticoagulation is as a major strategy for prevention. But what is less, realized is, in fact, atrial fibrillation is one of the biggest risk factors for developing cognitive impairment over time without manifest stroke episodes, right? So this is something that we don't tend to actually think about, right? We're just focused on anticoagulation and then, or cardioversion, things like that, and that's it, or ablation, right? And then not in terms of the long-term consequences. And so this is something that we now need to kind of begin to take into account because actually, patients tell us this is important. So but always not well in the brain and the heart front, even though, we think that we really, have heart failure now under control, we can really, sort of deal with cardiovascular disease. But in fact, if you actually look at the overall demographics, the concerning part is that we have had a really good success over time, but just around the time before the pandemic, in fact, it's leveling off, and now the trend is actually rising again in terms of cardiovascular disease. So heart failure is actually rising again. And in terms of dementia, of course, this is one of the biggest public health challenges that we have. And even though Leqembi and the treatments, may be available, but how do we actually even administer, in the population? And but the key that spurred us, to actually study brain and heart is actually patients. And the folks know that, there's a Heart Failure Alliance, in Canada, and led by Jean Rouleau and many others, Justin and Gavin is all involved in that. And but in fact, there's a very important patient partner, and across Canada, the patient partners led by folks like Gillian Code and Mark Baines and others, across Canada, when they did a survey, the number one concern, of the patients with heart failure across Canada, the number one concern is actually mental health. The depression, anxiety are some of the biggest things that they worry about. Number two is cognitive impairment. That's nothing to do, we worry about ejection fraction. We worry about, how many we have to target dose for medications. That's not what patients worry about, right? The patient told us, this is their biggest worry, and you are not even paying any attention to it. This is us. And the other things that they are most upset about is that, okay, finally, yes, you're depressed. You get your heart failure clinic appointment and all the rest of it. You need to wait 6 months before you can see the psychiatrist, right? Or you actually, get somebody who can actually, sort of help you with your memory loss, right? So this is really huge gaps that we have actually developed. But this is not addressing, our key concerns of the patients. So the patient really urged us, you've got to actually find a solution to the problem, and because we are bearing the burden. And so you may actually think that, brain and heart conditions, or, maybe a new problem. But in fact, so there are cases even in the early history, for example, Phidippides, he's the legendary runner, so folks know about, sort of the marathon races we have. So he actually ran from Marathon to Athens. Of this 40 kilometers, I guess is 26 miles, in 490 BC to announce the victories of the Greeks over the Persians. Evangelists should be very happy. And and he announced that we won, and then he immediately died, right? A lot of people, interpreters say that, well, that's why exercise is bad for you. You run too much. But in fact, if you actually carefully read the history, is in fact, Phidippides is actually a regular runner, right? Between the two cities, so he's totally fit. But the fact that he died, in fact, most likely is because of the excitement, of the announcement. And in fact, there are other cases, original Olympic Games, right, in which there's a pair of father and son. When the son won, sort of the first prize, both the father and son actually died suddenly. So there probably was actually a genetic predisposition, and and for that emotional trigger, and that actually, led to their death. And of course, subsequently there are more cases, in terms of understanding, for example, fainting, then people recognize that this is actually a combination of brain and heart issues. And so I think, even though this is scattered in the history, but, unfortunately, things have kind of grown in a separate direction over time. And some of this is because of the, sort of the realization of some of the special insights into disease processes. For example, Jean-Martin Charcot, and the others first actually started the neurology clinics because of the special population and special insight they had in terms of recognizing certain neurological conditions. And also in terms of cardiovascular, over time, the development of ECG tools, cardiac catheterization, CCU, ablation, so becomes a, subspecialty. And of course, people then focus on areas that people are most comfortable with. And so this then evolved, into separation, in terms of training, in terms of specialty, and we even have, heart institutes and things like that, right? But now we're actually trying to break down the walls, because the things that when you actually think about acute stroke and acute heart attack, the treatments such as thrombolysis, direct clot intervention, antiplatelets, there are so many, commonalities in terms of the treatments. The patients, sort of overlap with each other. But on the other hand, I would applaud, general internal medicine, geriatrics, pediatrics, intensive care do actually, sort of treat the brain heart together. And this is really actually, some of the paradigms we may actually be thinking about. But I just want maybe talk about a little on the biology side and in terms of the link between brain and heart. And so that it's not really just the patient's manifestations, but in fact, there are more than just meets the eye. So if even when we actually talk about Alzheimer's disease, and quite often, certainly my neurology colleagues tend to actually focus, more on the amyloid and tau deposition, in terms of the pathological features, and certainly the treatments, these like aducanumab or Leqembi and things like that, which are amyloid binders, are the initial treatments now we have available. But what is actually less talked about is that why these proteins actually get deposited, right? So the protein get deposited is not necessarily, due to presenilin mutations, things like that. Those are quite rare because the common forms of Alzheimer's disease is really a combination of both genetic predisposition, maybe ApoE4 mutations and things like that, but also most likely is actually the environmental factors, which are classic cardiovascular risk factors, that actually leads to microvascular changes in the brain, and that, lead to regional hypoxia, and that leads to stress on the neurons, and then in terms of protein deposition and activate neuroinflammation and leads to neuronal loss. And so these are the processes, in fact, are probably the key, in terms of acceleration of cognitive impairment, which is, of course, becoming more and more common, both in terms of chronic disease we deal with, and also aging of the population. And then if you actually look at it the other way around, for example, if you actually look at the website of National Institute of Aging or even Alzheimer's Society, you say, what are the things we can do today to actually prevent the development of Alzheimer's disease or progression of cognitive impairment? If you actually look at the, the things that people recommend, that includes controlling high blood pressure. You need to sleep well, eat a healthy diet, keep physically active, connect with family and friends. These are exactly the same things you would say, cardiovascular prevention. If you say you want to prevent a heart attack, right? Those are exactly the same ones, right? You really actually see the fundamental, foundations, in terms of disease process. And yet, we kind of think, here's Alzheimer's disease, here's a heart attack, right? It's really kind of keep them in artificial kind of separate domains. And I may just, show that, in fact, understanding, the interaction of the vascular component, and even in the treatment of Alzheimer's disease, can actually have really fascinating results. And this is, just a dozen patients that actually was reported earlier in New England Journal in terms of the amyloid binding agent. In this case, this is aducanumab, but I think it will be applicable to Leqembi as well. And as you know, most of the studies these days, is actually done using PET imaging agents that can actually label the amyloid. And then so you can see that in the baseline setting, there is actually very significant amyloid uptake, and therefore this could be a patient, having more aggressive forms of Alzheimer's disease and maybe a candidate, for the amyloid binding agent. But the clever part of this particular trial is the fact that quite often, when you have these treatments, it's difficult to actually access the brain in large quantities because of the blood-brain barrier. And so the investigators then actually applied a mechanical intervention that's localized the ultrasound to the brain. And but what they did is actually have the focus only on one half of the brain. And so that you actually have the intervention, you have the control arm. And you can see that the group that actually received the focused ultrasound to that, part of the brain that got exposure during follow-up in 26 weeks, you can see that in fact the effect of the amyloid binding agent in terms of removing the amyloid was way more effective. So it turns out that all you need to do is actually have an ultrasound exposure, for a limited time, like 20 minutes or something like that. And this will open up the blood-brain barrier for about 24 hours. And that's enough to actually, while you infuse the medication, you can see that the effect is actually very, very potent in terms of removing the amyloid with some improvement in cognitive testing as well. So this actually shows the interaction of even the amyloid deposition and the vascular component and impact on treatment as well. And that should also show that in fact this is applicable even in patients with heart failure, who we look after quite a bit. And so this is actually a study done by Matthias Friedrich, who's at McGill, was in Calgary earlier, and who's actually part of our brain-heart interact team and imaging. But I should give credit to also Elizabeth Hillier, who's actually medical resident here, and who actually helped to write part of the grant and was doing a PhD with Matthias. And also, I know I shouldn't mention this, but Ian Patterson, who's also the team doing this as well, but continuing the collaboration, with the team here. And so this is actually a very interesting technology that actually Matthias has developed, together with the team, in which one can actually use a combination of functional MRI imaging, which is oxygen-sensitive imaging, so that you can actually detect blood flow. But using interventions of just hyperventilation and breath holding, because folks know that if you actually undergo hyperventilation, your CO2 levels actually go down, and that will actually lead to vasoconstriction. But then if you actually breath hold, your CO2 levels will rise. That can actually lead to vasodilatation. So it's actually a very rapid way to actually manipulate blood flow in a short term, and then you can then capture using functional MRI, where the oxygen is actually located in the heart and the brain, and therefore, reflecting microvascular flow. So what happens is that when you actually undergo hyperventilation and then breath hold, in the normal setting, as the CO2 rises, the heart vessels will dilate, as well as will the brain vessels. But on the other hand, if you actually do the same intervention in patients with heart failure, just heart failure or regular, patients, particularly a patient with heart failure with preserved ejection fraction, and then they don't have any, cognitive impairment, at least clinically, so you will see that the patients with heart failure generally have limited capacity for vasodilatation. And this is, we always know that the microvasculars does not work well in patients with heart failure. And we demonstrated this before with PET, with the other studies as well, and using biomarkers. So that vasoconstriction is obviously, part of the problem the heart faces, particularly HFpEF. And that's, the purpose of many of the treatments to address that. But what is most surprising that even though these patients just have heart failure, if you actually look at their brain in the same patients, 70% of them have difficulty in terms of vasodilation in the brain. And in fact, when you follow these patients up, they actually develop cognitive impairment over time. So it really actually shows that the vasoconstriction problem in the heart is not isolated to the heart. There is actually a crosstalk between the heart and the brain on an ongoing basis. And so the cognitive impairment is not going to be a big surprise. In fact, it's fundamental to the pathophysiology, of the entire heart failure process and leading to, of course, cognitive impairment. And of course, brain and heart crosstalk, through the autonomic system, this is really classic physiology, so for example, the baroreceptors in the carotid artery, senses the hemodynamics, provide the feedback into the brainstem, and then of course it controls the cardiac response, but also controls renal response, peripheral muscle, so this is really the classic brain-heart connection. But now there is actually new data to suggest, in fact, the heart response can provide feedback to the brainstem, in fact, affect neural function and other part as well. So it's actually bidirectional crosstalk. But the interesting part, because I know at dinner last night, we keep on talking about, the importance of having good sleep and, and for function, so it's not just, what mothers tell us, but in fact, there could be a physiological relevance. And this is really actually a fascinating study, both in science as well as the more recently in terms of unpacking this. And so it turns out that when we are sleeping, as you know, during the daytime, the neurons, are very, very active. We're, using our brain, apart from those who are actually sleeping, which is actually good for you. And so, in terms of using our neurons, but there are a lot of toxic proteins gets built up. Right, and the proteins gets organized as becomes memory, but abnormal protein needs to be excreted, and this is where sort of a defective protein clearance in the brain, ultimately leads to the amyloid buildup. And so the interesting thing is that when you actually measure, in terms of how the protein is actually removed in the brain, it turns out that the lymphatics in the brain, the venous flow in the brain, is actually timed to the CSF flow. And the CSF flow is actually timed to the cardiac pulse. So all this is actually synchronized and using MRI. And this is particularly prominent during the REM sleep, during the deep sleep. So during this time, in fact, the heartbeat, regulates the CSF flow, and it actually regulates the protein clearance in a stepwise fashion. And so this is actually very, very, critical, obviously, for the, sort of a brain hygiene, from that point of view, and also removing the abnormal protein. And so you can imagine then in the setting in which you have either vascular abnormalities or you're not, sort of sleeping properly, or the fact that, for example, your heartbeats are not regular, right? So atrial fibrillation, you won't actually have as effective, sort of synchronization of this process. And therefore, the protein clearance becomes more impaired. Of course, it's very, very subtle over time, but it's cumulative, right? So this is why it's very important to have good sleep at night. But of course, exercise is also important because of that actually, help to maintain the health of this. I put these slides in on long COVID, for the benefit of Gavin. And so, certainly we know that patients post-COVID, do have long-term complications, maybe 30%. But we do know that particularly, the cardiovascular and the neurological systems are affected in this type of setting. Patients can have residual palpitations or the POTS syndrome, right? Which is really autonomic dysfunction. And now we realize that some of this is likely due to microvascular inflammation around the autonomic nerves that actually continue, to actually perpetuate the dysfunction. And then similarly, the neurological residual for patients in long COVID can be quite disabling. This cognitive impairment, the brain fog, that the patient experiences the profound fatigue. And a lot of this also involved the autonomic dysfunction, but also evidence of neuroinflammation, both in the brain as well as in the autonomic nervous system. And indeed, there's been, more data now using proteomic approaches and things like that to begin to understand that this is likely the virus residual effect that leads to persistent neuroinflammation, and that impairs the vascular function, and so giving you this brain and heart combinatorial impairment. which hopefully, over time can improve. But, obviously this is still continue to be a public health challenge. Last one, I'll just talk about this because I think Gavin, contributed to some of this very, very complex study, but really very, very elegant study, in which is very, very ambitious, taking a patient population, from various investigators, but looking at the brain and heart connection specifically through combination of genetic analysis, looking at the polymorphism and express QTL mutations that can actually cause disease, whether that's schizophrenia, depression, or, cardiomyopathy. And then look at the MRI of those individuals to do this genetic and phenotype mapping. Now, you would think that, if you have a mutation that's actually, related to the brain function, the impact will just be on the brain, and the heart, will be on the heart. But when they actually did a cross mapping of where the gene expression, for example, of these mutated genes are located, and particularly look at the phenotype mapping, what is most surprising is that there actually is crosstalk between the mutations affecting the CNS system mapping onto the heart and vice versa. This is something that you would never actually have thought of. And except, now these type of multi-omic technology, for example, even in patients with schizophrenia, in terms of the potential mutations, in fact, some of these map directly onto the cardiac chamber in terms of development and abnormalities, and the vice versa, in that the patients, with atrial fibrillation, right heart failure, in fact, actually show some of these gene expression abnormalities also in the brain. And so this really actually indicate, so much of the development and also phenotype, genotype correlation crosses the organ, and not in kind of our organ-specific, sort of localized manner. So it's really actually based on some of these observations, but really what patients tell us, spurred us to actually begin to investigate this area and put an ambitious grant program together that Evangelist mentioned earlier. And this is the Brain-Heart Interconnectome SFRF, but together also with our Heart and Stroke Foundation team grant, the BRIGHT grant, in which Justin and others are also part of as well. And so was co-designed with the patient. The vision is actually transform the prevention and treatment of brain-heart interconnected conditions, as we mentioned earlier. So going from the scientific underpinnings, to the clinical impact. So the idea here is that we actually look at the fundamental epidemiological and also basic science linkages, between the conditions, and then begin to actually look at the kind of the clinical impact that we can actually make, whether that's on the biomarker imaging tools. I kind of illustrated some of that earlier. And then in terms of the therapeutic opportunities, and then look at earlier disease intervention, sort of even in childhood, so we can actually, have a healthy a lifetime trajectory in terms of brain heart health, because the focus of these are really actually common, just when we mentioned the risk factor management, right, is actually common. And, development of new guidelines and also health system interventions. But this is truly classic interdisciplinary research, bringing some of the, best people in medicine together, right, solve problems that has a large impact. And beautiful Edmonton in the morning, right? This is just unbelievable. So I may just take the license of actually giving you one example, and apologize to those who may be at the talk yesterday. This part does actually overlap a little bit, because we've been very much interested in biomarkers, related to the heart, and particularly heart failure with preserved ejection fraction using proteomic techniques to identify, a large portfolio of these. And one of them is IGF-BP7, that's insulin growth factor binding protein 7, which interacts with IGF-1, which is a senescence receptor, and also insulin receptor, which of course regulates metabolism. And so, took us a lot of time to try to figure out why would marker like IGF-BP7 even show up, in the setting of heart failure. And indeed, if you actually look at the patient population who present acutely with heart failure preserved ejection fraction, IGF-BP7 is as good, if not actually much better than NT-proBNP in terms of detecting the heart failure and defining the heart failure phenotype. And the IGF-BP7 turns out to be a member, so-called the senescent secretome. So as the cells age, in fact, they elaborate cytokines like IL-1, like IL-6, but the IGF-BP7 is one of these inflammatory cytokines that actually accelerate the senescence. And so it ties in, obviously, with the aging population associated with HFpEF, the microvascular abnormalities, and also the diabetes phenotype. So it really actually ties this all together, but it's actually measurable in the blood. And so the lucky coincidence to this is that we got this candidate through proteomic analysis, but in fact collaborators in the genomic consortium, the Hermes consortium, which just looks at at the etiological genes accounting for heart failure using genetic methods, is also searching for candidates as well. So they, as Tom Lombers, from UCL in London, led this global consortium involving over 153,000 patients, and particularly look at HFrEF genes and HFpEF genes. And so, in fact, just by luck, that the HFpEF genes, there are only two that actually are very prominent. And these are completely, sort of non-hypothesis driven, based on data. And one is the GAL-NT8, which regulates galactin, sort of sugar coating on the cells in terms of cell-cell communication and matrix. But the other one is actually IGF-BP7. So it really actually suggests that IGF-BP7 not only is a protein-based marker, but may actually be etiologically, linked to the development of heart failure with preserved ejection fraction. And there are many studies, validating IGF-BP7 as an excellent predictor, of outcomes in patients with heart failure. But an interesting one is this study from Roberto Latini's group in Milan, looking at the Italian population, over 2,000 patients, elderly patients, who are fine to start with, but followed over time. And indeed, what they found is that all the different biomarkers available, IGF-BP7, GDF15, are the best predictors of mortality, heart failure, hospitalization, cardiovascular death over time was highly, highly significant. So it really suggests that this aging marker probably is actually fairly pathologically relevant, right? So that it's really taking an elderly population, you can actually track out. Of course, it really a number of them do develop a heart failure with preserved ejection fraction as their disease process. And so we've been actually looking at some of this, over time, and it suggests that IGF-BP7 particularly leads to aging of the microvasculature. So some of the same theme come back. Indeed, patients with abnormal brain, imaging abnormalities, their IGF-BP7 levels tend to be high as well. But what is most surprising to us was the fact that IGF-BP7, when we actually tested it in different cohorts, originally was in an atrial fibrillation cohort, but then later on in a cognitive impairment cohort, IGF-BP7 comes up as high as the classic neurofilament light, which is a neuronal death marker, one of the best for looking at neuronal damage, and as well as looking at the tau ratio, or the phosphorylated tau ratio or amyloid ratio, which are the gold standard at the present time for detecting Alzheimer's disease. And so we've been trying to figure out, you gotta be kidding, is IGF-BP7 even involved in the brain as well? So we actually did this experiment, classic experiment in which you have a heart failure model in the mouse. And so this is a banding model, or myocardial infarction model is the same. And so usually there is actually very little IGF-BP7 expression in the brain. There's a little bit around the coronary plexus, because this is involved in the microvasculature. But on the other hand, in the mouse, if it's actually subject to myocardial infarction, if you actually look at the 2 weeks later in the brain, you actually have IGF-BP7 lighting up in the brain. And this is really actually talking about, a heart failure marker. And that is, very predictive of microvascular aging, but also showing up in the brain. So, and this is the most humbling moment in which, again, shows our blind spot as well. So IGF-BP7 in the brain, we think that, there'll be no literature on it. But in fact, that's not true. You look up IGF-BP7, in fact, IGF-BP7 turns out is very important for cerebral vessel development. So it just shows you that we, a good thing there's Google and, all the rest. And glioblastoma secrete IGF-BP7 to induce abnormal vascular formation. It's been actually reported before. And in fact, IGF-BP7 is elevated in a post-traumatic brain injury, likely, sort of in terms of the hippocampal vessel malformation. Of course, hippocampus is critical for memory and for emotion as well. And in fact, post-operatively, IGF-BP7 is elevated in patients, after anesthesia. It actually correlates with subsequent cognitive impairment. So all these scattered data to suggest that, in fact, IGF-BP7 is very much actually linked to cognitive impairment. And so it was not actually an accident, likely, in terms of knowing that IGF-BP7 regulates microvasculature. It's a great, predictor for heart, outcomes, but in fact, it's also linked to the brain. And in fact, it's active in the brain as well. And so there, in fact, there are many other examples. BMP10, for example, is one of the best markers for predicting development of atrial fibrillation. And it turns out it also actually is expressed in the brain. So we really now begin to realize, in fact, many of these processes actually are interlinked. It's just that, happen to be where we tend to focus clinically. And so now, we beginning to actually look to see if we can actually block IGF-BP7 in this disease setting. Certainly in the preclinical model, we have antibodies that can actually block IGF-BP7, for example, once heart failure has taken place, and it can actually reduce mortality, reduce the cardiac adverse remodeling, and the heart failure phenotype. And so we're now looking to see, in fact, this can improve brain function as well. So I think now, there is a kind of a paradigm, which suggests there can be shared or crossover genetic predisposition, protein biomarkers that help us to understand the process. But it's actually the organ, sort of mutual dysregulation that leads to the adverse outcomes, and that actually has a common, biology, but probably, sort of have organ-specific impact, obviously. And the question now is, can we actually use these markers to begin to actually detect the risk earlier as our patient requests, and therefore, have better, or at least targeted intervention, or, more focused risk factor, prevention in these patients, so that we can actually change the natural history trajectory, prevent, heart failure, cognitive impairment, which is really top of mind. And I don't have time to talk about renal failure. In fact, the brain and the heart and the kidneys are all linked together, so, colleagues know that well. So just the last few comments in terms of opportunities. I know Evangelist, was talking about, population study in terms of genetics. So actually, one of the major components of the Brain-Heart Interconnected grant is actually a data platform to bring together the genetics, proteomics, and the clinical outcomes, eventually develop an open science cross-linked platform for, people to collaborate. And so this is a data platform that we are actually not developing de novo. So there will be going to be, sort of 3 components. There's a patient and public component. We're working with Heart and Stroke Foundation on this, and a healthcare provider component in terms of guidelines, literature, and things like that. But it's actually this researcher component, which we're particularly working together with McGill Neuro, Dr. Dr. Evans from the Montreal Neurological Institute has actually had a previous CEFRAF to develop a huge, collaboration cluster. And in fact, for neuroscience folks, this is actually the new gold standard for collaboration, not only for across Canada, but in fact now several of the major NIH, multi-center programs now request the data to be residing on this platform for sharing, as well as some of the European Union, and the platform just linked up with the UK Biobank as well. It's really actually the gold standard. And so we are working with this to bring the cardiovascular component to it, also working with CAMH in Toronto to bring the mental health component to this. And eventually, we think this is going to be, really the basis, a very large-scale collaboration platform. And already the features on this platform include not only, the biobank data, as I mentioned earlier, but also in terms of the clinical data, in terms of the ability for you to upload, your data system, and, to have the, I think the nice thing about this feature is that every data element has the consent level, built into it, as well as the comfort of sharing level by the investigator, so that you can actually control this on an ongoing basis. And so there's also big data processing tools and simple to use tools, whether it's actually for genomics or for proteomics, and also for multi-omics, and to link to clinical outcomes. And also in terms of producing publication quality, outputs, and the ability, to actually have groups, to develop, collaborative projects, so you can actually interact on the platform. So this is the concept, this is the evangelist mentioning, the ability to potentially, accommodate the studies that folks want to work on this. And so I think the opportunity going forward include the collaboration, whether that's on the various mechanisms, so whether that's on the microvascular side, on the inflammation side, and even show this paper from Evangelist's earlier days, that even in terms of dichloroacetate, which is good for the heart, but also for we'll count the glioblastoma as the brain, connection, and so in terms of looking at the, the opportunities to look at common etiologies. And in terms of clinical collaboration, of course, in terms of sharing epidemiology data, adding neurocognitive parameters to cardiovascular trials, right? And, just, so we do clinical trials, we count the number of myocardial infarction, heart failure, hospitalization, and stroke, etc. But we actually never measure cognitive function, in the patients, right? It's as if, the heart stopped. The clinical trials for cardiovascular system stop at the neck. And and in fact, we are collaborating on the clinical trials. The Converge trial is being led by Dr. Justin Sikowitz as part of our collaboration, evaluating VERI-CGuat, which is solid guanylase activator, which is already approved for heart failure in patients with heart failure and mild cognitive impairment, to see, in fact, this can actually help in terms of the cognitive outcomes as well. And the health system intervention, so because there's no question that there are opportunities in which you can have better care for our patients. The stroke teams are already kind of working on this, in which the patient with stroke can be screened, for example, for atrial fibrillation and those aspects, but also, going forward in terms of a cognition for these patients and the preventive strategies. And so having patient partners, in these are super important, because for patients, this is top of mind and a very high priority. Upstream target risk identification and ability to actually use novel markers or imaging strategies. We're developing new guidelines. The C-Change Guidelines version 5 is going to be focused on brain and heart, interaction. And then, as I mentioned earlier, this may be a little challenge. I was chatting, because we're working very closely with the Ontario Ministry of Health to, in fact, integrate a number of these novel approaches into the health system. But we like, so we previously have Alberta as actually as a team, so maybe we'll figure out, after a little bit of restructuring, to pick up the collaboration. So really actually putting all this together, whether it's on the area of epidemiology, share risk factors, underlying mechanisms, coordinated, sort of early diagnosis and therapeutics, health system innovation, the opportunities here, and really look forward to the collaboration that we can actually forge, with everybody. Here's another beautiful picture from Edmonton. Thank you very much.
Thank you, Peter. We only have time for one or two questions. Is there anything from here? Yes, Gavin.
Yeah, thank you so much for your presentation, and thanks for including it. So, the other piece to this that's coming up now, it's a bit uncomfortable to be getting into, is the gut microbiome and gut health. And it's from the COVID stories, one big changes with COVID phase 2 in the gut, that it's a big driver of endothelial cells and all of the microbes to repair. You see, so lots of preclinical and now going into clinical findings. So I think it would be great to have that piece added to the story in terms of a major determinant of cardiovascular and also.
So Gavin's comment was that there is evidence that the gut participates through the microbiome to this axis.
Yeah, and so we actually had that, but we didn't include in the grant because it would be too many organs. Yeah, and absolutely. And in fact, we've done some work to show that the gut is actually where the system, whether that's on the blood flow side, but particularly immune, right? Regulation, as well as the metabolic regulation, takes place. Absolutely. And so this is can be both pathophysiology, but it also could be therapeutics as well, right? So these are good opportunities. Yeah. So that's why I say the gut and the kidney, all the others are actually linked in, but we focus on brain and heart for now. So just so that we can sort of have the patient population.
On the same line, these factors this advice that you showed for Alzheimer's, this lifestyle advice is exactly what characterizes the blue zones in those 7 areas on the planet that people live 80 without dementia, without heart failure, without osteoporosis. And now this is considered to be sort of the hallmark for healthy aging. Another way of looking at this axis is that with time, age as a disease advances and carries everything along, the brain disease and the heart disease, among many others.
Yeah, absolutely. It's a bit similar to the cholesterol story. It used to be blood pressure, right? You think that when you get older, blood pressure should just rise, cholesterol will rise, and then that's fine, right? But now we realize, in fact, that that's not fine, right? And so, in fact, the ability for us to mitigate, right, all these parameters early on. So the key is that, we now think that the data suggests that it's actually in the 40s and 50s, where you actually can have the biggest impact. And so that's why, early intervention, which we usually don't pay attention to, is actually where the biggest impact from public health point of view. So,
okay, we have to stop on time. And thank you, Peter, once again. We will remember your vision from inspiring talk from yesterday and the things we learned today for a long time.
Yeah, so thank you. Thanks for the invitation. Look forward to the collaboration.